It led me to go and investigate how big this problem is. I didn't know 10 doctors a month in the United Kingdom kill themselves, of which 3 of them are GPs. I didn't know this figure.
Welcome to Health Chat, the UK's #1 health and social care podcast. We discuss the most important issues in the healthcare sector and the challenges our colleagues face from the front line of delivery to decision-making in the boardroom. Join me, your host, Dr Bhagat, as we speak with interesting people from across health and social care and bring you expert insight and discussion on the topics that matter most to healthcare professionals. Hello everyone, welcome to episode 3 of Health Chat. I'm Dr Bhagat, Medical Director at Health Group, and I'm honoured and privileged to be here with my friend and colleague, Dr Bhagat. Dr Bhagat is an NHS GP and he also has a thriving practice in North London and is founder of GPDQ, a health tech innovated service developed in London. Now there's a lot to get through. Dr Anshu, I've got so many questions and I know you've got a lot to share, so we're going to get through as much as we possibly can in the short time that we have available. First and foremost, the introduction I've given doesn't even touch the surface of all the things that you're involved in, the things that you have founded and innovated. So for the audience, would you please explain more about what you do?
Firstly, thank you for your very eloquent introduction. So foremost, I'm an NHS GP at it, and that's kind of really where everything I do starts from. I'm an NHS partner. I've been a partner in North London in Enfield for about coming up to 18, 19 years, a doctor for about 24. And I say that because it's the grounding of everything I do. My NHS work is the most important part of my career, my life, and to be honest, drives every bit of innovation even. I'd say all the innovation that we're going to talk about stems from the challenges that we have in the NHS, I think, and that's the so you know I'll always say that's, you know, we're a teaching practice, a training practice, and all the wonderful things for the future of doctors. I am a private GP, and private general practice, when I started private general practice 18 years ago, was a bit of a dirty word, really, amongst my own colleagues, and I think. Looking back at it now, it was probably a lack of understanding and of how it worked. But you know, apparently you could pay somebody to just give you antibiotics, and that was the kind of theme that was going around about private GPs. But actually, for me, it was purely built around access. If I wasn't a doctor, what would I want for my children, my family? I'd want accessibility, and it probably drove how I delivered that service. I delivered it in a very personal way. People had my mobile number, and I know plenty of people are going to go, this is barking crazy. And it seemed like that at the time. But actually, it proved to be the most successful part of this. Actually, we improved accessibility so dramatically where you could WhatsApp the doctor. I have rules, please don't get me wrong. So that's that side of things. And then we launched GPDQ, which is about, again, built around accessibility. How do we make GPs more accessible to the public? And that grew, and we are now a UK-wide, not necessarily a direct-to-consumer business. We now only provide to a B2B setting. So we power different organisations by providing fully governed services. We're actually the only multi-channel healthcare provider in the UK, and that means home visits, remote and face-to-face. We're not a locum agency, and I always use that in the sense that we fully govern the services with our partners jointly. So, and then in more recent times, I've now gone into a bit more of the secondary care space and that again driven by the problems that we have. And you know we have one of the biggest problems we have is we have 7.9 million people on the secondary care waiting list, and yet we don't know how we're going to truly get this figure to an acceptable level. And when I say an acceptable level, remember it's a constant flow of activity. You can get rid of 5,000 people, but 7,000 people have joined the next day on that list. So to even sort of comprehend how we're going to manage this, we've got to really start thinking of solutions that are slightly different, which hopefully we can expand on.
Mm-hmm. Now, let's go back to the history of our meeting. You mentioned GPDQ. At the time, I believe I joined about 2018, 2019, around that time. Quite a revolutionary concept where it was an app-based technology. People could book home visits via an app. They could get in touch with the GP. And this was at a time where a lot of the teleconsulting companies started developing. But as you mentioned before, you had the best of choosing different methods for engaging with a healthcare professional. Just tell us a little bit about the background, the thinking behind it. What prompted you to develop that, and how have things changed since then?
I think it was just probably an extension of how do we improve access. You know, the concept was, everything that we were hearing was you can't get to see your doctor. And, you know, lots of funny memes around how receptionists were sort of viewed as, by the public and in terms of the doctor blockers and all of these sort of things. So accessibility was always a kind of a major issue up there. And what we decided to do, and we had to prove a point, which was, can you make doctors accessible through technology, considering we can have private transport delivered to your home via technology, you can have food delivered to your home via technology. Why couldn't we deliver healthcare physically, as in, we're not talking remote medicine. Remote medicine kind of probably came a little bit after that, really, when it kicked off. But actually, we're talking about the moving of human clinicians to the patient. And I hate to sort of use this language, but the sort of Uberification of doctors and trying to do it at a price that supported doctors and doctors felt that they felt worthy, but also at a price level that the public were willing to accept. You know, and I always said, if you can get a plumber to your house cheaper than we're getting our doctor, I'll pay for the plumber. And that was the sort of, the jokes aside, but that was the kind of theme of it. Now, several challenges in this model. Remember, in the UK, we are blessed with the NHS, and you know, I'll always start there. The NHS trained me. I will never leave the NHS. I am committed to it until my last working day. However, it doesn't mean that it hasn't got problems. And I always see, you know, my views of the NHS are so, I'm so bonded to it, that I kind of think of it as a sick relative. I have to be there to nurse this. I can't just walk away. This is my family, you know. So that's the kind of relationship I see with the NHS now, is that it needs support, and it needs support not just from doctors, not just from government, and not just from patients. And we mustn't forget patients, because patients, the NHS needs patient support as well. So we really went down a road of how do we sort of improve that access and start to introduce some interesting technology. Now, you know, back then, it's common technology now, but 10 years ago, 11, 12 years ago, trying to get that level of technology, it was really owned by the major providers. And so we went into a space that was effectively connecting a demand and a supply. And it, you know, it worked really well. And I think, you know, the concept of technology as a whole, I think is you know, if we think where we were 10 years ago and where we are now, we take things for granted now. You know, in our daily practice, you know, I have all sorts of widgets on my screen. I can go straight to a video consult, straight to email, straight to text. I can communicate with my patients in all sorts of manners. But 10 years ago, that wasn't necessarily the case, you know. And so I think technology is wonderful, but it aids the people who deliver the healthcare. And there's different types of technology. One is there to assist you operationally, and then we can park the type of technology that may assist you diagnostically, AI, et cetera, and I think that's a whole different afternoon, Atif. But I think the concept of how do we start to make technology work for us as the clinicians is key. You know, we can only go back, quite frankly, when I started general practice, I think we were only 2 years, sorry, when I became a doctor, we were only 2 years writing into an electronic system. So, you know, we were writing on paper and all of that. And, you know, so think how much just in my life, my career, things have moved on from a technology perspective, and we've had to adapt every single time. oh gosh, I'm never going to type on a computer. Oh gosh, and now you've got that, I'm never going back to paper. So I think we've all got used to technology assisting us in our lives. But for me, that's probably what I need technology to do. I need it to make patients' lives easier. And if it makes patients' lives easier to access us, to get information across to us, and vice versa. If we can use technology to assist patients, but really it doesn't replace the clinician. We can, we've all seen the views of how AI was going to apparently replace your job and my job, and you'd go to a computer screen and say all your things and it would spit out a prescription. Now we know that's not going to happen. Remote medicine is the closest thing we've got to that, but at least you're working with a human clinical brain. Do I think it doesn't have a place? I think it will have a place in co-assisting diagnoses and coexisting real-life clinicians making decisions and making certain aspects of healthcare safer, to be fair, as well. So I think I think technology has a role. But what I've probably got to in my point of my career is that I want to focus on the people that are actually delivering the healthcare, because if we don't focus on the actual people that are doing the work, you don't have a health service.
Mm-hmm, mm-hmm. So a lot of collaboration, a lot of cohesion, because it's very easy to accelerate in one particular process, but if you leave everyone else behind, again, another broken system, which we'll come on to.
Yeah, I think, the word broken system, I think there's lots of great systems, except they all work in complete silos. Mm-hmm. And that's the challenge, is that whether we're talking about the NHS and the private sector and the electronic health record system, everyone's using it, none of them are talking to each other. We haven't even truly, only until recent times, have we managed to connect acute care, secondary care and primary care. And even that's not quite as smooth as I would necessarily like it. So I think we're going in the right direction. I think the vision has been there for a long time. The creation of the spine was exactly that we all, my dream would be that, imagine seeing all primary care and all secondary care and all community care and all mental health care notes in one medical record. Now that's the vision. Mm-hmm.
Now, the next question's quite involved, so forgive me if I'm reading from my list here, but technology, budgets, sometimes very difficult to go hand in hand and deliver on both. So with the recent UK budget allocating significant funds to support NHS productivity, especially through digital technology, how do you see GPDQ's technology-driven model aligning with this vision?
I think we need to have a bit of a word of warning here. We can stick millions and millions and millions into technology, and I don't for 1 minute think that technology is going to be helpful. I do really think it's going to help us going forward. But we mustn't lose focus, because I think technology is always going to be, it's going to be the wind under our wings, is how I would put it. It's not going to do the flapping. And the flying and the flapping is going to be you and me, and our wonderful clinical colleagues and nurses and doctors and quite frankly, all the way down to the staff that clean the hospitals and everyone that works in the NHS. This is where we truly need to focus. And whilst I appreciate, we've got technology and there's some wonderful things we're going to apply that technology with, I think we need to focus on operative efficiencies first. Mm-hmm. So before you start putting more different layers of technology on, I think you've got to sometimes unravel things that are already in existence and go, well, we can't just add this on top. Let's try and break it down and redesign. So I think it's going to require some efficiencies operationally to make sure that the pathways that we're developing are going to hold up. Mm-hmm. Like I said, I think technology can often be, at best, can improve our lives, but at worst can be a complete distraction. Mm-hmm. And that's the balance that we just need to get.
And are there any particular tech innovations that you believe could directly reduce strain on NHS resources?
When we say strain on NHS resources, I think, it's a big question, that, in terms of any technology that we think we could reduce the strain.
I guess waiting times. Or...
So,
inefficiencies in certain areas?
So I think this short-term things one can do. You know, I'm thinking about the NHS that I'm going to leave my children. And when we start to think at that scale, nothing happens change-wise. Really, it takes a good generation for things to change. And I'll give you an example. The biggest public health improvement that this country did probably in recent times was the banning of smoking indoors. Mm-hmm. Now, we can all go back, I remember it clearly. I remember people smoking on an aeroplane. So, you know, and the day that you couldn't smoke on an aeroplane or you couldn't smoke indoors there was marches on the street. There were people saying, you can't take away my liberty, and all of this sort of stuff was going on. And so now think of that. If somebody lit up a cigarette quite frankly, even in a bar, everyone in the room would turn around. And you can see it took a generation effectively to turn that into something bad. You can't be smoking indoors. This is ludicrous. Now, so where am I going with this? I think the long-term longevity has to involve patients, because when we're talking about a public health service, mm-hmm. it's funded by the public, it's for the public. But if we don't start to understand that one of the biggest contributors to consumption of healthcare in the country, some of it can be preventable. So when we talk about obesity rates, smoking rates, all of these different things that I think we need to really start to focus on, and above and beyond the way that we've been focusing on it, because I don't think anybody could say that, well, we're not. You could say to me, well, it's not that we're not focusing on obesity, Anshu. Of course we are. But absolutely. The question is it making a difference? Mm-hmm. And it isn't making a difference. Smoking, well, wow, that made a difference. But you saw the stick. It was no carrot there, very much a stick. We're going to ban smoking as of this day. Like it or leave it. We're going to double the price of tobacco. We're going to tax it to the hills. Nobody at any point now you'd go, well, I think it's completely acceptable, right? Because it's a thing that, it's a habit that contributes to poor health. Poor health contributes increased burden on the NHS. So, and obesity, we know, is arguably the biggest global problem we have. You know, if I go back now 20 years, I'm the diabetic lead in my surgery. So I used to diagnose about 1 a month diabetics, and we used to use impaired fasting glycemia back then, the glucose drinks, and maybe 1 of those a month as well. I'm diagnosing 3 new diabetics to 4 new diabetics a month, probably 2 pre-diabetics a day. Wow. Now, if this is not a bomb that's gone off, by the way, and this is a study I've done in my own surgery, this is nothing short of a non-acute pandemic. I mean, this is you know, that level of seriousness. And so the question we've got to ask ourselves is, how are we going to ask a population that contributes to, like I do, you do, the public contributes to healthcare. How do we get them on side to say that we've got to take some self-responsibility? And there's different tools when we talk about technology that we're looking at. You know, one of the things that I've been spending some time doing recently with one of my new partners, that we're looking to integrate, for example, a health score. Mm-hmm. Now, I'll give you an example. Credit score, we all understand that concept. We all understand that if you don't pay your loans and your mortgages in time, your credit score goes down. The next time you go and get a loan or credit, they'll say, no, you can't have any more. Or if you do get it, the rates are going to be higher than somebody else. Similarly with life insurance. We all know that somebody as fit and healthy as yourself, you go and get a certain quote, but if you smoke, you were double your body weight, you had a positive family history of this or this, and you had a lifestyle thing, your rate's going to be higher. Now, but we understand that. I don't think anybody, you know, when we talk about carrot and stick, I don't think anybody would go, I can't believe you're charging me more. Well, we understand why we're charging you more, because of your lifestyle, your habits, and the things that come with your risk. Yet we don't necessarily apply that to health. And when I mean health score, we all know now with wearables and lots of people, and the actual behavior changes that these things do. And what do we do with that information? My own children, my son will go, oh, I've only done 9,500 steps today, and he'll go in the garden and start playing until he gets it to 10,000. That's changed his behavior. Or somebody's gone, the things they tell you about sleep, and somebody will go to bed earlier because their watch said that they didn't have a good night's sleep last night. Now, whatever this is, these are behavior changes based on data aggregation. And when you start to put different pictures together, you can start to create a health score for somebody. And the wonderful part of something like this is that how do we change human behavior? Because we've got to get to the crux of why is the nation getting bigger and bigger and bigger. We can reflect on food laws. We can up the price of your fried chicken on your high street and all of the other things, or whatever the strategies we've used so far. I'm afraid none of them have worked. And so we've got to start to think the same way your credit score has changed your behavior. You won't default on a loan because you won't get a loan again. Similarly, if you default on yourself, i.e. you don't do the exercise, you don't get the weight down, you don't stop smoking, all the other things that may increase or lower your health score, even the smallest things can change human behavior. So I'm really interested in that aspect of things. How can data for an individual change the behavior that they do? Because at the moment, there's one impactful way we can say that it does, because this is wearables, but this doesn't connect to my insurance company. But if it did, I can guarantee you evidence has shown globally that it changes human behavior. And so I'm just looking at new ways of trying to make sure that we have a sustainable NHS. And one of them is, as the public, we do have to take more responsibility for our own actions and our own health. I don't think any public funded system can just cope with anything.
Sure. Interesting viewpoint. So I want to talk about supporting primary mental health and primary care mental health and retention amongst healthcare reforms. So the budget also highlighted the need for productivity and efficiency in healthcare delivery, but primary care mental health and retention remain major challenges. As a leader who's advocated for mental health support for GPs, how do you think the healthcare system can balance productivity demands with the well-being of healthcare providers?
This is a massive cavern you've opened up here, and I don't think we're going to truly do it justice today. But I've spent the last 15 years of my life working to improve the mental health of my colleagues. It was really driven by a GP colleague 15 years ago that killed himself. And I thought this was going to be big news in my naivety. I thought this would be, oh gosh, we're all going to be talking about this and it might be on the news and all of this. No one, didn't hear anything. It wasn't even in our GP press, wasn't in the local press. And I just suddenly thought, well, that's interesting. Started looking into the data of how many doctors or how many GPs actually kill themselves. And I know this is always these type of morbid discussions, but they're real. And when it starts to sort of hit home, and you forget all the people that are struggling, suicide is your end result. There's a world underneath that of people, whether it be not coping, stressed, etc., etc. So, and I'm one of them, by the way. I don't think that I regularly, do I have small little moments regularly, 2 or 3 times a week? Absolutely. So my point is it led me to go and investigate how big this problem is. I didn't know 10 doctors a month in the United Kingdom kill themselves, of which 3 of them are GPs. I didn't know this figure.
Wow.
Right. Stark. And I know, and I don't want to ever make a doctor that killed themselves any more special than anyone else that killed themselves. Absolutely not. And I think we could talk about this wider and reflect on men in general. The majority are men, absolutely. And I think that's probably another debate again. But I think the the challenge what I found upsetting was that who's listening to us? You know, yes, we have organisations that are specifically set up to support doctors, but you know what I've learnt in all of this is that we were trained as clinicians to give our all. You know, we weren't. I come from a generation of, you know, when I first started my first house job in 2001. You know, I don't think there was any hours of limit of hours you to work. You just worked until your job was done, and your boss was your consultant, and you remained obedient throughout the entire thing. And there was no number of hours. No one was interested in how many hours I've been up. Right? Is the job done? So I come from that, but now looking back at it, thinking, if that was my son, do I want them going through that? I think it's, I'm not saying it, you know, what I'm saying is that it's completely unreasonable to ask somebody to do that. But again, not everyone I know, even in my year or years above and below, have coped as possibly well as I think I have. So my point is that it's taken down people. You know, our career, the career that we went into to be, to learn learn medicine and to be blessed with that, you know, to be having to do that course, I think is an immense blessing. I'd never reverse it. But I think the challenge will be, whether it be type of work, working hours, the conditions that you're working in. This isn't just primary care, Atif. This is secondary care. I have colleagues in secondary care that I speak to regularly about how they're not coping. So, look, in summary, without, again, sort of going too gloomy, is that this was a mess pre-pandemic. Now, there's two elements to the pandemic. I think the pandemic brought us together, a disparate workforce. People actually found positivity in pandemia. It really was like I haven't got time to be stressed or depressed now. I'm going to get up and do my job, and actually gave a lot of people some hope to focus on, because everyone was in the same boat. And it's an interesting human psychology for us to understand. If I'm the only one that's feeling like this and everyone else seems to be coping, you feel an outlier. But when you see the whole country struggling like this, there was, you know, so it really brought people together. I think those are the wonderful things of it. I have some strong personal views, and my views are that we all went out on a Thursday and clapped for us. Yet we didn't increase the nurse's salary to an acceptable level. So, you know, I have, and I appreciate there's a limited pot of money. I appreciate that we're in a pandemic, and this is, you know, you just got to do what you've got to do. So I appreciate all of those things. But the workforce is what makes the NHS work. You know, if I said in my own GP surgery, you know, even in primary care, when I speak to my other GP colleagues, we are arguably holding up the NHS, not bitterly. And I will never want to come across and say that, because I'm here to serve my patients. That's my only objective, is to make sure my patients get a fantastic service. And I'll go above and beyond. But it does mean, when I say above and beyond, I'm delivering above what I should be delivering. And that's just how doctors operate. But what we can't do is fix the NHS off clinicians' backs. And that's the bit that I want to get across. I mean, I'll give you an example. I don't allow GPs to work in my surgery for more than 6 sessions a week. And I say that because you need to know I'm not going to be responsible. And I advise people, go and do something different, right? You know, funnily enough, I work 5 days a week in my surgery, but I can't work all day, every day in my surgery, because I will be struggling with my own mental health by the end of this. So I make myself do other things. Not because I'm out chasing money, or I want to do this or I want to do that. I just don't want to do that all of the time. I want to do a bit of something different. So the portfolio career, which I think we're all very familiar with, it all started with PCTs turning into CCGs, you know, and we all had different roles, and it got us out of the surgery, and quite frankly, I loved it. But I think the long-term vision is that those people that, remember, lots of people work full-time in primary care, in secondary care, what are we doing for that population? All right. There isn't a doctor that I speak to, and just to give you an idea, you know, we have a community now of over 740 clinicians, of which about 450 are GPs, 500 are GPs, and then the rest are ANPs, pharmacists, physios. So when I mean the clinicians, I mean everybody, that we're all in the right place, in the right frame of mind for sustainability. You know, so I don't think I've got the answer as to how do we improve mental health. I think talking about it, number one, calling it out. I think ego, as doctors, we are, and we have our own pride that comes with that. We forget sometimes that we can be patients. And I see that in myself sometimes. I can't be ill in front of, or I can't be, So I think we've got to start talking about it more. We've got to acknowledge it more. But most of all, we need to reduce the pressure within the workplace. And when we talk about a system, and I'm sure we're going to move on to this, but, our Prime Minister himself has said the NHS is broken. Our Health Minister has also counteracted that and agreed that the NHS is broken. Now, these are strong words, and especially when I'm in it, you're in it, as part of the service provider. It can be, it's nice to hear that somebody's acknowledging it, because I've reflected on this for many years. I think we were way on our knees in 2005, 2006. Things were going significantly down. I just want to make sure that the offering we have for our staff, for the clinicians, the receptionists, everyone, we need to make their working lives better. Because at the moment, the work never stops. And how do you separate your work life from your home life? And everyone that works in the NHS has the right to a home life. And I think that's the challenge, which I don't think is going to be an easy one. But the concept of the NHS is broken. Let's have a debate of how we plan to fix it.
Given your focus on diagnostics and preventative care and some of the things that you mentioned before, what role do you think independent providers like GPDQ, like your own, the London Diagnostic Clinic, what roles can they play in supporting the NHS to reach those goals faster, to improve accessibility, early intervention, and how might the new funding priorities affect your approach?
I think we need to step back from this, because sometimes when you're deep in it, you lose all objectivity. And I've had to really think like that and think, well, you're just quite biased because you're delivering it and you're slightly burnt and maybe a bit bitter and all of those things, which I try not to be. I really do. But I think when we talk about sort of solutions, for me, if we remove things from the table of things that can fit in terms of options, then we're not doing this right. For me, everything has to be on the table for reform. Otherwise, we're moving chairs around on the Titanic, right? And that's not what I'm prepared to be involved in, because that's all I've done. That's all I've been involved in for 24 years working in the NHS, is we've been just shuffling things around. There's a lot of robbing Peter to pay Paul. But however, this is that's not a bad thing, because it's a fixed budget system. It's a public funded system. There's no endless budget here. So I understand the economics behind it. I did my master's in advanced commissioning to understand money in the NHS and purchasing powers and trusts and primary care and how we're going to fund this. And at one time, the NHS was, it was a beacon for the world. But I struggle with it now, calling it for a beacon for the world, because as a frontline GP, I feel embarrassed often. And when we talk about, you mentioned diagnostics there, and absolutely we know that lots of funding has gone into community diagnostic centres and all of these, and I run a diagnostic centre, so I totally appreciate, absolutely, I always call diagnostics a doctor's should be in a doctor's toolbox. You know, a plumber would never come to your home without a spanner and a bit of whatever the tools a plumber needs. And as a GP, I need X-ray, I need ultrasound, I need bloods, I need a set of things that allow me to be the detective, the clinical detective, which is what we are. That's all very good, and diagnostics has improved. There's no two ways about it. The question is not, and I think primary care, it's struggling, but it's not broken, but we're in a really, really tough place. And we always forget that 90% of all patient activity in the United Kingdom happens in primary care, yet we only receive 10% of the budget. So I think we need more money. And this is the dirty word. You know, we'll always talk about reform and pathways and efficiency and all of these things. But the reality is it's the Titanic and the chair, right? That's all we're doing. I will never move away from efficiency. I think efficiency is really key. But the reality is that we're doing a sterling job in primary care for the money that we get paid for it. It's nothing short of amazing what we do in GP land. The challenge is you can see your GP now. You can get diagnostics now. Secondary care is a mess. So I can refer somebody with all the package and there's diagnostics and everything's ready to go. And by the time they get to see somebody, all of that's really old. The ultrasound scan needs repeating, the MRI needs repeating, the bloods need to be repeated. We're back at square one effectively. So the question for me is, how do we get treatment pathways looked at in a different way? How do we go from GP to patient has been dealt with and discharged by secondary care within 8 weeks? Now that for me is a premier class service. And I compare our health service to other models around the world, the Netherlands, Japan, Singapore. Let's start to look at different contributory models, government contributory models, self-pay models, you know, and you can go through all of these things. And kind of where I've come to on this is that we've got 3 options, Atif. Increase the NHS budget by 50%. Throw in another 90 billion in that. Now, option 1. That's not happening.
No, I can't see that happening at all.
And I will also, and plenty of people hearing this will say, well, you can't just throw money into it. We need, I totally agree. It's not just a money problem. We need efficiencies. We need organisation, reorganisation, however we want to look at this. But remember, we mustn't get clouded by reorganisation. I'll give you an example. When we do love a bit of reorganisation. I've been through many of them. If you remember the setting up of CCGs, the setting up of ICBs. Now, I'm not sure how successful that's been. And one could debate that, and that would be another podcast. So the question for me is, and those reorganisations cost millions and hundreds of millions, tens of millions, hundreds of millions nationwide, billions nationwide, sorry. So we've got to be mindful that I totally agree, not just throwing money in and not just reorganising for the sake of reorganising and all of these things, and that's a given. But it's not happening. We're not getting another 90 billion to do anything. Option 2, ask patients to pay. Now, oh, I see everyone say, I can see the room go silent at this point. I will never be an advocate for patients paying. We started this with our services being free at the point of use, and we need to make sure that it remains free at the point of use to the patient. So we're definitely not going to be asking patients to pay. However, remember, globally, very few countries offer what we offer. The majority of Europe has a GP copay or a pay of 50 euros or whatever it is, 60 euros, something like that, or a copay system. So we're aware of how other systems work. And I'm not suggesting that their systems are better, nor does that achieve better outcomes, because in certain cases it doesn't. And I think we've got to look at the evidence there. But that's politically I'm not comfortable with that. I signed up for this wonderful thing as the NHS. Now, what's the third option? Or what have we got left on the table? I think employers have to take a role. Employers, i.e. the working age population, A service needs to be provided to that working age population by employers. Now, for all the employers that are listening to this, I know what you're saying because we talk to you all the time. I haven't got the money that a large oil company or a large pharma company or a large legal firm has to spend £250, £300 per month per employee. I don't have those budgets, and I totally understand. So the employers actually are saying, give us a product that actually is affordable. Give me a bit of a tax break on it. Make it an employment right to receive healthcare via an insurance product. And you'll say, well, what's that product? I'm talking about a digital front-end primary, a full access to face-to-face and diagnostics across multiple networks, including the NHS, but multiple private providers. And we have to involve the private sector. I'm just echoing what our government is saying. The public-private partnership is what's going to get us out of this, because the governments aren't. We're going to have to involve the private sector. We're going to have to involve the employer market to be able to contribute to the country's, nation's health. And that way, patients may have to contribute a little bit via their existing NIs, and maybe it'll go up a little bit further. But I think the employers will be contributing the majority of it. Patients will be contributing a tiny small amount of it, and the government will be contributing a little bit via tax rebates, etc. But what I'm trying to get at is you have a full digital front-end primary care system. You have an entire face-to-face network of diagnostic centres and doctors that sit for face-to-face examinations. Not everything can be done remotely. And then there's certain pathways that you move into secondary care for. If you move 70% of secondary care activity out of existing, as in, nobody wants to do urgent care, ambulance, transplant, complex surgery, cancer, severe mental health. The NHS is the best globally for this type of stuff. But it's getting a bit of a bad rap because it's busy doing lots of other stuff that it shouldn't necessarily need to do. And you know, when we reflect on this, and I look at Lord Darcy's recent paper, and you know, it's quite frankly, it's two identical papers, 16 years apart, but why aren't we listening to him? Why aren't we saying that this is actually a solution, that we do need to bring secondary care out of a hospital? I already run similar systems, and this is not some sort of plug, I'm just trying to test a system as in, does it work? Why do we need, for an over-the-desk consultation, a big building with the lights on? Why can't I have a neurologist, a rheumatologist to do my scans in the community, do my consultations in the community, document on one record in the community? So getting that, and going for minor surgical procedures, your cystoscopies, your hysteroscopies, your colonoscopies, your endoscopies, all of these things that people are just waiting and quite frankly rotting on a waiting list. It's awful for the patient, certainly doesn't do anything for the clinical outcomes, because that's unmonitored. We don't know what the true clinical outcomes of this delay is. We won't know for many years to come. So we need a conjoint system that sits completely outside, as in a call it a national health network, a network that delivers primary care, secondary care, diagnostics face-to-face, and actually up to 65 to 70% of all clinical activity can be dealt with in this model. Now, if you remove the entire employed population out of that, because it's now being driven and powered by employers, you actually free up a quarter of the NHS's resources. These are solutions. Again, I'm not saying this is the best thing since sliced bread, but I've spent many, many years analysing our systems, our processes, our funding channels, our growth vectors. How do we actually start to merge? And remember, in all of this, we're focusing on reactive care. This is reactivity. Where's the proactivity? How do you stop people getting heart disease? How do you stop people progressing down certain pathways? You know, we still know that obesity, diabetes, COPD, heart failure remain the sort of 4 largest causes for hospital admissions. So I think there's a whole public health improvement part, and I think the public need to be involved in this. We need to help our nation get fitter. We need to reward people that contribute to that. And arguably, I might be shot down here, I don't want to call this a stick, but we do need to make sure that we, with support, help people that need that support to get healthier. Because nobody says anything when your car insurance goes up because you've crashed 5 times, or your life insurance goes up because you smoke 50 cigarettes a day. Nobody goes, oh, I'm being victimised. Well, no. So healthcare for me is no different as a trading economy. We get sensitive about it because it's health. But everyone and every part of this discussion is about improving people's health. And that's the focus here, and I don't want people to take that the wrong way, but we've got to truly think of solutions that, and I think the employer solution is probably the only solution we have that's truly going to make a meaningful difference.
I think that there's a lot to consider, and certainly surely doing exactly what we've been doing without any changes is not the right thing to do. So
I think that's a sign of, if you're expecting a different result, I think we call this delusional. Yes.
Correct. Coming back to elements of tech and compliance and regulatory things, and you're involved in so many things, and you've reorganized, as you mentioned earlier, and CQC's always been inspecting and watching what you're doing, and we all go through the audit processes and things. In terms of the systems that we use for monitoring, for instance, in Health Group, we have software called Health Manage that organisations can use on a traffic light system just to see where they're at. How are there documents in place? Are they dated correctly? Is everything up to scratch? As time goes on, in terms of the monitoring process that are ongoing, do you still see these? Are they challenges to what you're trying to do? Do they hold you back, or are there ways that we can engage with the monitoring organisations and regulatory organisations to facilitate this amount of change?
So I started medicine before the CQC came about. So I've got to say, everything that I've been through many inspections across different organisations over the years, and I find CQC. I know this is going to sound really nerdy, but I find the concept of CQC a very appropriate one. I think we've absolutely got to make sure that we are doing what we say on the tin, that we're doing it safely, that we're doing it properly, that we're doing it with patients in mind. I think there was probably aspects of it that became outdated and it needed to change. I think it became a very, I know that 3 days prior to my CQC inspections, clinics are being cancelled, patients get less appointments, doctors are not doing this because they're preparing, staff are doing it. So it affects the service delivery. And I found that a little bit difficult to swallow, which was, this shouldn't affect my service delivery on the day, where a whole day is being taken and we're looking at things. And that means we've cancelled a clinic, we've done. And whilst I appreciate there's no other true way of doing it, I think the concepts were all fantastic. How do you remain safe and effective and good leadership and all of these wonderful things? I'm a bit nerdy like that, so I quite like to show that we're doing a good job. I like, and before we didn't even have technology. We had a spreadsheet and we went through it, and policies were all on Word and all of that sort of stuff. So I think, but it needed to change, I think, for sure. I think the biggest challenge that probably in my own personal career, because I run 4 different things that have different CQCs, is it's not in one place. Mm-hmm. And so I've got 4 different versions of how I do it. Not versions, but 4 different sort of, one's using this software, one's not using software, because it's too small maybe, but do you know what I mean? So there's just, it's slightly disparate, when actually the content and the core sort of blood that runs through all of this is all the same. The concept of making sure that you can prove that the quality of your service is fit for purpose is kind of how I see this. So I think it's an important process. I think technology has to help us here. I find aggregated data sitting in silos a really frustrating thing. Well, that's sitting there, well, it's on an Excel or it's on a Word, and you've got folders on a computer that is, there's 2 different versions of the same thing, and all of these things that we've encountered. So I think having software that brings it together, especially if you've got within one account, different companies. Now, that's something I'd love to explore, where I have one main account, because I'm the registered manager for all of them. So my brain, my whole life is governance. That's pretty much, I see patients and I deal with governance, and that's it. So I think technology is absolutely going to be my friend here, for sure.
And I have to congratulate you all the way back then when I remember GPDQ was one of the first, probably the first hybrid provider that actually got outstanding status with CQC.
Hybrid, yes. Yeah, I mean, look, it was not just me. Don't get me wrong. I have huge numbers of people to thank, not just me. So that would be very unfair. But I think the concept is especially as things are changing now, and actually, that's probably an interesting thing to reflect on now. As somebody who's deeply involved in governance, I didn't quite know what was going on with all the change. I didn't understand statements and we statements and what does this mean, Why would you change something? We had our S1 to 9 and all your Chloes were there. They were there for a reason. I love my Chloes still. I still actually run the Chloes in the background because that for me is my checklist. So I think, I don't think I'm still 100% clear, to be honest. I have governance teams, don't get me wrong, and they are definitely, but we've had a bit of a hiccup. I think the CQC has, as our governing body, it's important that we support that organisation as well to make sure that they survive, that we give them feedback, which I have done as well, and to say for the better, to say, look, we shouldn't be doing like this. So I think we need to be involved in how we're governed as well, and I think this new approach hopefully should start to break down the fear of it as well, because it's once I think I've done about 6 of these, 7, maybe 7, I don't know, but your first one it's a shocking event. I think I came home and slept for an hour, after my first CQC inspection. So I think that world needs to be, so to be quite frank, any help, I know the wonderful things you guys do, and quite frankly, breaking that myth down and that fear down. What's interesting is I'm a GP and I spend a lot of time with governance now, but it takes me away from patients. I think as clinicians, it's important that we understand governance, but we need to be left alone to do some clinical stuff. Doctoring. I'm happy as Larry seeing patients. I struggle when I'm now going through audit things and this and that and too much of the paperwork and granular stuff. And then that's where, that's the stuff that would burn me out. So it's getting that balance right. And I think, anything that makes our governance lives easier is a yes from me.
Anshu, you've been an incredible guest. So much to reflect upon, and I'm very excited to see where you lead your organisations, and let's see what the future holds. And hopefully someone in an important position has listened to this and reflected on it and will take some of the suggestions that you've made quite seriously and implement them. Thank you very much indeed.
Thank you for having me. It's been a wonderful afternoon.
Once again, thank you so much for joining us. I hope you found that podcast engaging. Please do share, like and subscribe, and watch the space for more content. We are the Health Group. We work with the new and existing healthcare providers every single day, from private clinics to adult social care services and NHS trusts, to ensure all providers are compliant with regulations, have a culture of excellence, and are delivering exceptional care.